We're truly grateful to have Dr. Andrea Hermosura, Dr. Rebecca Delafield, and Dr. Joseph Keawe Kaholokula for graciously sharing their research, time, and recommendations on this essential topic. Dr. Hermosura is a Native Hawaiian Assistant Professor in the Department of Native Hawaiian Health and a licensed psychologist at the Queens Medical Center. Her research interest includes health inequities, how factors like perceived racism and implicit racial bias impact the health inequities experienced by Native Hawaiians and other Pacific Islanders, and community-based participatory research. Dr. Delafield is an assistant professor with the Department of Native Hawaiian Health at the University of Hawaii John A. Burns School of Medicine. Her research interests includes maternal and perinatal health and healthcare disparities impacting Native Hawaiian and Pacific Islander communities, implicit racial bias, and community-based participatory research. In addition to her academic research, Dr. Delafield is involved in various initiatives working to improve health in Hawaii and health equity for Native Hawaiians and Pacific Islander communities locally and nationally. Dr. Kaholokula is a tenured professor and chair of Native Hawaiian Health in the John A. Burns School of Medicine at the University of Hawaii at Manoa, and a licensed clinical psychologist. His strong commitment to achieving health equity for indigenous communities is also reflected in his service and on the national level as past chair for intervention research to improve Native American Health Network, current co-chair for the Asian American Native Hawaiian and Pacific Islander Special Interest Group of the Community Engagement Alliance, and his past appointment to the National Advisory Council on Minority Health and Health Disparities. In Hawaii, he has served on the boards of organizations with a mission to improve population and Native health, including the Queens Health Systems, Hawaii Public Health Institute, and Papa Olak Lakahi Native Hawaiian Health Board. He is a co-lead of the Native Hawaiian and Pacific Islander COVID Response, Recovery, Resilience Team for Hawaii. As a Native Hawaiian, he is passionate about improving the health of Native Hawaiians and Pacific Islanders and has made a lifelong commitment to improving their social, cultural determinants of health. I would like to thank Deborah Zeisman and Ryan Catalani from Hawaii Children's Action Network on the coordination of this presentation. Each of the presenters will share the research findings and recommendations of historical, cultural, and social determinants and of health for Native Hawaiians and Pacific Islanders. Please, if you can hold all your questions, as we will hold a Q&A session after the last presenter. Enjoy the presentation from our three wonderful presenters. Thank you.
Aloha, everyone. Thank you, Brandon, for that introduction. My name is Rebecca Delafield, and I'm going to be speaking with you to start this presentation on contextualizing maternal health in Hawaii. And then I'm going to pass it over to Dr. Kaholokula, and then we'll circle back to talk about some contemporary issues with Dr. Hermosura after Dr. Kaholokula's presentation. So thank you again to HCAN and to Department of Health and the Maternal and Child Health Branch for having us here. It's good to see so many people have taken the time to come and listen to this presentation. And I know some of you from different areas of my work and life in Hawaii. So I'm very happy to see you, and to those of you who are new to this presentation and to us as presenters, I'm so glad you have taken the time to be here today. So we are going to talk about research and data, but we're also going to talk a lot about stories and narrative. And I wanted to start this presentation the way I've been starting a lot of presentations lately, with a picture that grounds me and helps me remember who I am and why I'm here. So this stone is called a lattice stone. It's near the house where my grandmother used to live. My grandmother lived on the island of Tinian, but she was born on the island of Yap, which is now a state in the Federated States of Micronesia. She moved to Tinian after the Second World War, where our family was originally from. She had family in Guam and throughout the Mariana Islands. Her mother died in childbirth, and then my grandmother gave up her education to help raise her younger siblings. She married and had 13 children and lived a long life and had many grandchildren, and I was her first grandchild. She passed here in Honolulu at Queen's Hospital, and my children were born here in Honolulu as well. And I'm giving you this context because I feel like these experiences, along with many others, have shaped how I think about the work that I do and the questions that I ask as a researcher. So thank you again for taking time to come and listen to these perspectives that we'll share with you on the issue of maternal health and as it relates specifically to Native Hawaiians and Pacific Islanders. So we're here and we're going to talk a lot about health disparities. And one of the things I've encountered in doing the research that I do on health disparities generally, and then specifically in the area of maternal health, is that sometimes when a group has poor health, there can be a tendency for some to think that it's because the group doesn't value health. The field of public health, in fact, for a long time attributed many of the differences that were seen by population to specific behaviors. But more and more we're understanding that disparities on a population level, particularly for marginalized groups, are not reflective of a lower value for health, but in unequal access to resources and opportunities to have optimal health, and to histories of explicit systems that disadvantage certain groups and result in neglect or even assault on health for those communities. So this presentation hopes to share the historical and contemporary impacts that Native Hawaiian and Pacific Islanders experience and talk about some contemporary challenges, including implicit bias. So again, the image on the screen is of a latte stone, and that's part of the foundation of ancient Chamorro houses. So the stones were underneath and they were lined up in a row, and then there was a thatched house on top. They're only found in the Mariana Islands. This particular one at its highest was about 15 feet tall altogether. And so they were built around between sometime in 1000 AD and 1500 AD, prior to Spanish colonization. And I hear sometimes they're referred to as ruins of ancient society, but through my lens, I see them as an emblem of resilience of our indigenous community. And they've survived through hundreds of years of colonization, through a world war, and modern shifts to this landscape that's continuing to change around our islands. So I see them actually as evidence of strength and of resilience in the face of challenges. And I think that's something that we want to talk about and share about today. So the objectives of this talk will be talking about maternal health disparities a little bit, and then the historical and social context of these inequities in Hawaii for Native Hawaiian and Pacific Islanders, challenges to health and well-being today, especially in regards to negative attitudes and stereotypes and bias, and explore the role of implicit bias specifically in healthcare, and recommendations for advancing equity at multiple levels. So we'll end with kind of strategies to help manage bias at the individual and institutional level. And this is not going to be a presentation where you leave and you have all the answers. It might just raise more questions for you. So I want you to think about this maybe as the beginning of a conversation if you haven't had some exposure to some of these things previously. So maternal health is a sentinel indicator of the health of a community. It's looked at a lot in terms of global health indications and as a measure of some of the development of a community on that scale. But since 2000, maternal mortality and morbidity in the United States have been increasing. And this makes us unique among high-income nations. So here is a slide that shows the maternal mortality ratios in selected countries in 2018. And I have an arrow pointing to the US rate, which is 17.4 in 2018, but it's actually risen to 23.8 in 2020. And while that's an important indicator because it represents in 2018 over 660 maternal deaths in that year, it's also important to look at the other arrow that's pointing down to New Zealand and New Zealand's rate, which is 1.7 deaths per 100,000 births. And that's important to note too, because what it shows to us is that for New Zealand, a nation with over 20% of population that identifies as Maori, which is another Polynesian community, or Pacific Islander, they have the lowest rate among these nations, or ratio among these nations of maternal death. And it also says that the deaths that we're seeing in these other nations are actually preventable deaths, right? So that's one of the things. And actually studies done in the United States looking at very carefully reviewed maternal deaths have shown that up to 60% of the deaths that have been reviewed were preventable. So while the increases in maternal mortality are fairly recent and kind of go against the pattern that we've seen over the past century, the racial inequity is not new. In the US, Black women are 3 times as likely, and American Indian and Alaskan Native women are 2 times as likely to die from a pregnancy-related death compared to white women in this country. And then what you'll see here, this is the same slide, is that Asian and Pacific Islanders don't seem to have the same disparity. However, so that might seem really good for Hawaii, but if you look at this information, we know that actually Native Hawaiian and Pacific Islanders have higher risk factors compared to their white and Asian counterparts in terms of lack of prenatal care, in terms of certain socio and demographic risk factors, and in terms of other outcomes that we've looked at, including infant mortality and preterm birth. There are disparities if you disaggregate Asian and Pacific Islanders. The unfortunate thing is that we have no national data on maternal death that's been disaggregated for Native Hawaiian and Pacific Islanders currently. However, thank you to Dr. Stacy Tsai and Dr. Macon for publishing on just 2 years of, I think it was 2 years of research that was done into maternal deaths here in Hawaii. So we do have something to look at. And what we found is that of the 25 deaths that they were able to review, 44% of them were among Native Hawaiian and Pacific Islander women, which is a huge overrepresentation compared to their population and an overrepresentation compared to the percent of births they represent in our state. So this is a problem, even though we don't have good data for it on the national level, that needs to be investigated. The causes of racial disparities are not fully explained by medical risk factors and socio-demographic risk factors. So you can see in some of the research that education will not influence, for Black women specifically, the disparity that's seen between white women and Black women in terms of maternal death. And so we know that medical conditions such as diabetes and hypertension will play a role, but they do not account for the differences in outcomes that we see. And so we need to look at other possible explanations, including historical trauma, the experiences of racism, and implicit bias. So there's some challenges to investigating maternal health in NHPI populations. One, there's not enough available data, and people haven't been doing work to really try to use what is available to examine some of these issues. But when we do disaggregate data, we do see differences between Native Hawaiian and Pacific Islander groups. So that's an important thing to know, that there is heterogeneity within these groups for sure, and also within some of the outcomes that we've seen. But there are also similarities, which is also important thing, is another important thing to note. Even across states, we see similarities, for example, in C-section and in the experience of negative attitudes and stereotypes towards different groups of NHPI patients. So this is just a brief example of some of the quotes from the research that I conducted most recently, asking women about their experiences with maternity care. These are all Native Hawaiian or Pacific Islander women, and they talked about several different topics around the issue of perceived bias and discrimination, including insurance status. So one of the women said, I feel maybe because I'm covered by Medicaid and I know they look down on people with this type of insurance, so they just use me as a guinea pig. So she had an experience where she felt like the care she was getting was not about caring for her, but about a particular agenda that the providers had. Secondly, around language, for those that needed interpreters, I feel like the people that work here kind of are like irritated by it. They treated them a little differently. So this is actually someone who I interviewed because she qualified as someone who had just given birth, but she worked in a healthcare setting. And this is what she observed specifically around working with patients who are from Micronesia and needed language assistance. She felt that the providers were treating them with some irritation because of the extra assistance they needed with language support. And then finally, we're still fighting like to be respected or to be counted. Yeah, like to be treated equally, right? So that was another person who identified from a Micronesian community who was talking about, I think what she was saying was why she might not have said something in the face of a discussion with her provider about her own care. So now Dr. Kaholokula is going to take over and I'm going to stop sharing screen. Thank you very much. I'll be back in a few minutes.
Aloha, everyone. Velina me ke aloha. Mahalo, Dr. Delafield, for that opening and setting the stage. And actually, I'm going to go back in time to further set the stage for what's coming up after this talk with Dr. Hermosura and Dr. Delafield. And I'll be talking about, in a broader sense, historical, social, and cultural determinants of health for Native Hawaiians and Pacific Islanders. But I start by saying that there is very little studies that have been done among Pacific Islander groups. And a lot of the studies that have been done are primarily among Native Hawaiians, but often aggregate Native Hawaiians and other Pacific Islanders. I'll try to make a distinction where I can. And I do admit that I use the Native Hawaiian experience as an example of the historical, social, and cultural determinants of health. I like to start a talk when we talk about health inequities on a good note. And I want to start on this good note. If we look at the baseline, if you will, of what the health was for Native Hawaiians as well as other Pacific Islanders across the Pacific, if we take a look at the journals of Captain James Cook and his officers from their expedition here in the Pacific, who wrote extensively about their experience, their observations of the Native populations across all the Pacific, what you'll find is some common descriptions of our ancestors. Here in Hawaii, one of the officers observed a very healthy, robust populations. As you can see from the quotes here that I have, the Native Hawaiians of these islands, the natives of these islands are in general above middle size, well-made. They walk very gracefully, run nimbly, and capable of great fatigue. Quite different than, unfortunately, our current health status, where a significant number, over 50%, might be considered obese. But also the social and psychological well-being of our people was also observed as being very healthy, very robust, very friendly, if you will, counter to what a lot of the narrative was with other foreigners coming to Hawaii, depicting Hawaiians as savages, depicting our Pacific people as being terrified of the elite, the oppressive elite, and being waiting to be sacrificed. That is not what Captain James Cook and his officers observed when they first came to Hawaii in 1778 and throughout the Pacific prior to that. I start off with this because we often talk about biological and genetic factors, as Dr. Delafield expressed, in understanding health inequities and understanding health inequities as if to blame an ethnic or racial group on their health inequities. But really, the Pacific people, the peoples of the Pacific prior to Western intrusion, was quite healthy and robust, a thriving population, as evidenced by all the behavioral observations of the communities prior to Western intrusion on these islands. Here in Hawaii, and it's similar, but in different, but also in different ways across the Pacific. Here in Hawaii, we're very familiar with the depopulation, occupation, and discrimination of Native Hawaiians that has placed us at a disadvantage in our own homeland. In the 1800s, we're aware of the infectious diseases that devastated our population, that nearly wiped us out. The population was estimated to be roughly between 700,000 to 800,000 natives at the time of Cook's arrival in 1778. But that declined by over 95% by the late 1800s, the turn of the century going into the 1900s, to barely 30,000 Native Hawaiians, mainly due to infectious diseases such as cholera, influenza, mumps, measles, whooping cough, smallpox, among others. And of course, with the COVID-19 pandemic, we also were reminded how many of our Native communities are most vulnerable to infectious diseases. Again, as we'll talk more about, not due to biological or genetic deficiencies. Certainly, I'm not ruling that out as a possibility or even contribution to health and well-being, but certainly it probably is not as a big contributor or determinant as we think, compared to other social and behavioral determinants of health. So as we know, there were rapid and drastic changes to our traditional social, political, and economic systems. There was a banning of our traditional practices and banning of our traditional healing practices, especially that could have offered many of our Hawaiians and even today opportunities for prevention to prevent a lot of the chronic diseases that we're seeing in mental health concerns. Eventually, we lost our kingdom to a U.S.-supported coup d'etat that deposed our sovereign, Kuanili'ukalani, in 1893. Eventually, we were annexed to statehood, made statehood in 1959. Of course, all under protest by Native Hawaiians. And the reason I'm bringing this up will become apparent because, again, colonization is now considered, or it has always been among Native people, but now recognized in the public health community, in the global health community, that colonization itself is a determinant of health. And as you know, there's a suppression of Native language and customs and a marginalization of Native Hawaiians that led to tremendous discrimination in education, employment, and housing that continues today. Dr. Bushnell, who wrote this book with the ironic title, Germs and Genocide in Hawaii, The Gift of Civilization. This is a quote from that book. And as he noted, psychological traumata of almost intolerable intensity and variety afflicted the natives at the time, and that he considered this a new psychological stressors that were above and beyond the stressors or the experience of the chronic that was caused by the infectious diseases and the microbes that, as he described it, that had played a role in affecting the health and well-being, the longevity, and the population in general of Native Hawaiians. Na kanaka o ku'uvale aku no uhane is actually a saying that comes from that time in the 1800s when a lot of our ancestors were being decimated by these infectious diseases, and it translates as the people dismissed freely their souls and died. I bring this up because I'll be shortly talking about historical trauma and the role that it plays in health and the health of a population. Before I get there, again, highlighting some of the significant health disparities. Contrast this to what Cook and his officers witnessed and observed in 1778 at the dawn of Western contact. It observed a very healthy population. They actually go further to describe in their journals how they could not find any evidence of major illness that they usually found in Europe from where they were from. In fact, most of the problems they saw was really disability due to war among the men. So injuries gotten from war, but issues around diabetes and heart disease and so forth and cancers, of course, probably was not as much as an issue as it is today because of the lifestyle at that time. As we look at Native Hawaiian and Pacific as compared to non-Hispanic whites, we're considerably a greater risk for a range of chronic diseases and mental health conditions. You can see them on the left and the magnitude of risk there compared to non-Hispanic whites, just to highlight a few leading causes of death: cancer, heart disease, unintentional injuries due to accidents, stroke, diabetes. We get chronic disease 10 years younger on average than other populations. And there's been several studies that have shown this, especially with stroke, for example, that we're more likely to get it 10 years younger. we're also more likely to have hypertension, unmanaged hypertension, despite being under physician care, that may be contributing to the higher rates of stroke. We also die a decade younger on average than other groups here in Hawaii, whether that's Native Hawaiians, Samoans, other Pacific Islanders. 22% of our populations report 3 or more chronic conditions, comorbid conditions. 75% of Native Hawaiians, I haven't seen any work specifically Pacific Islanders yet, that report greater than 1 adverse childhood experience, and there are significantly more experiences of adverse childhood events among Native Hawaiians when compared to other ethnic groups here in Hawaii as well as nationally. 30% underinsured or uninsured. 15% of our communities live in extreme poverty. In Hawaii, this is probably based on national averages. So here in Hawaii, that's probably a little higher because of our cost of living. And we make up a vast majority of the houseless communities here in Hawaii. So there are significant issues. When we look at mental health issues, both nationally and here in Hawaii, we have more mental health issues, greater suicide, substance use and abuse, more psychological distress being reported over the past 30 days, over the past year, compared to other groups in the United States. More adverse childhood events, as I mentioned earlier, more depression, psychological distress. And when we talk to Native Hawaiians and other Pacific Islanders and ask them what might be the source of the higher risk for mental health issues as well as physical health issues, and we always get, and I'm providing an example here in the bottom right of one of the studies we did with Native Hawaiian women, that cultural loss and related stressors with the cultural loss and here in Hawaii with Native Hawaiians, the loss of our kingdom has caused significant depression, but well, as I'll show later, it's also associated with chronic diseases, chronic disease risk. When we look at the determinants of health, and this is based on actually extensive work that I've done with community partners as well as other investigators over the last 18, 20 years, looking at what really affects the health and well-being at different levels, kind of take a socio-ecological framework approach to this. As you can see there in the figure, these are the big ones that most often come up as either challenges, either barriers or facilitators to health promotion for Native Hawaiians and Pacific Islanders. And as you can see at the geopolitical level, discrimination, where one lives, sovereignty issues play a bit is something that's affecting the health and well-being of our Native Hawaiian community, especially food sovereignty, food security issues, the built environment, and so forth. And many of this, I won't spend too much time on that, but I want to pay particular attention on the far right that these are the major issues that we're seeing in our communities. These are the determinants of health factors. And determinants all can be positive or negative, right? If I make a lot of money, that's a positive determinant of health. If I'm underpaid, can't afford to buy food for my family and so forth, that's a negative aspect of determinant of health. Here are some. Historical trauma is an issue, self-determination, cultural revitalization. Not all of these are bad. These are good things. Like cultural revitalization, for example, is an asset in this case. High levels of discrimination. We know from numerous studies that Native Hawaiian and Pacific Islanders are more likely to live in environments that we consider obesogenic, meaning that it lends itself to obesity. There is unusable sidewalks, there is recreation or parks that are either unsafe to use or not kept up. So therefore they're unusable. We're more likely to live in toxic environments, as well as overcrowding in our communities that lead to other safety issues. There's food insecurity. We know from a lot of studies here in Hawaii now that Native Hawaiian Pacific Islanders have more in food insecurity than other groups. Lack of livable wages is a challenge for all of us. And I'll come back to this shortly. Inadequate education opportunities, low healthcare access, immunization, and high levels of childhood diversity, as I pointed out earlier. Now, I'm focusing here on adverse birth outcomes. I know so not so much maternity, maternal mortality, but definitely infant mortality, but does affect the mother as well. And I want to make a point here about how the social determinants of health are playing or operating to affect the health and well-being, or in this case, adverse birth outcomes. We know that it's associated with race and ethnicity alone. There are significant differences in the rates of adverse birth outcomes in various ways, depending how no matter how you look at it, across different ethnic and racial groups. It is higher among Native Hawaiian Pacific Islanders in many studies, are among the highest. We know that racism, especially interpersonal racism, structural racism as well, but right now I'm talking about all the studies that were done were pretty much interpersonal racism. And racial segregation also shows that as an impact. When we look at socioeconomic status, and we can break it up in several different ways: income, maternal education, food insecurity, impoverished living conditions, all found associated and often independently associated with adverse birth outcomes. And one of the biggest things that we're seeing now is that adverse childhood events, and the more you have, the more intense they are, the more frequent they are, and the more they are in the numbers of events that you have, it increases one's risk for adverse birth outcomes. I want to highlight this particular article from the American Journal of Public Health because it really shows, because we're struggling here in Hawaii, right? It took a long time for us to even get to a point where we want to raise the minimum wage to $15 an hour and follow other states that had done that. And for some reason, for a long time, that was debated, that didn't go through. And now, of course, $15 is no longer a livable wage in Hawaii because we waited so long. But this study is a national study that looked across all the states that had initiated increases in minimum wage law, a change in their minimum wage laws to increase minimum wage. And what they looked at was among low-income women. So they examined the effects of changes in the law of increasing the minimum wage and its effects on adverse birth outcomes in low-income women. And what they found that was for every $1 increase in wage, there was a 1 to 2% decrease in low weight births, and 4% decrease in post-neonatal mortality among these low-income women. And this is a large sample size, and it was significant. So as you can imagine, just income alone has an effect on a person's risk, or in this case, a woman's risk, especially from low-income community, whether or not they're at risk for an adverse birth outcome. And you can imagine that this would be similar for maternal mortality as well. So when we look at the historical trauma, historical trauma is kind of a perspective that has been promoted among many indigenous researchers and healthcare providers to understand the situation that indigenous communities, but not just indigenous communities, African-American community, for example, being descendants of slaves with also a similar history of being conquered and being oppressed and marginalized, is that we're finding that this concept of historical trauma, one of our studies that we're just working to get published right now, show that historical trauma or a sense of historical loss is associated with depression in Native Hawaiians, and it's independent of racism. And I'll just talk more about that soon. But it is a psychological wounding because of past and current transgressions. It is a type of intergenerational trauma that gets carried forward. And as you can see on the far right, the pyramid here, we know from numerous research with other populations that historical trauma is associated with adverse childhood experiences, and therefore adverse childhood experiences affects the development or impairs the social, emotional, cognitive functioning of young people. It leads to adoption of health risk behaviors. Ultimately, it leads, and we know there's a strong association between adverse childhood experiences as well as chronic disease and psychopathology in adulthood. And actually is associated with early death as well. So these are factors we cannot ignore, that there's something happening here that is beyond a biological or genetic explanation, but also beyond the explanation of just lifestyle choices. And as Dr. Delafield pointed out, it's not simply that people are choosing to be unhealthy or don't want to be unhealthy. Life is pushing them in a particular direction because of their social circumstances. And a lot of times for Native indigenous people, it is this historical events that really put us at a disadvantage in our own homeland. And as you know, with the Hawaiian situation, made us second-rate citizens, especially after the overthrow. So I want to focus in, I want to hone in on one particular aspect of the social determinants of health that's related to the historical issues that I previously overviewed, and talk about racism among, here I'm talking specifically among Native Hawaiians. There's emerging work with other Pacific Islander groups. And when we asked Native Hawaiians, and we have, although I cite one study here in 2014, there's been a number of studies since then that we've looked at issues of racism and racial oppression among Native Hawaiians. And when we asked them over the past 12 months, over the past 30 days, in this example here, over the past year, the degree to which, on a multi-item scale, degree to which you felt racially oppressed or discriminated against. And what we find is that 40% of Native Hawaiians report feeling racially oppressed often to most of the time. 52% sometimes. I don't think we ever found none of the time, or any percentage reporting none of the time. So there's a lot of perceptions, at least, of racism among our Native Hawaiian community. I use the word perception of racism because that's what we're measuring, right? We're not following people to actually observe what's happening. We're going off what they're saying. So what they're perceiving and what we're assuming is there's a lot of racism out there that they're experiencing and that they're challenged by. But how does this affect the health of Native Hawaiians and other Pacific Islanders? And over the years, we've been able to do a number of research projects looking at the role of racism, in this case, interpersonal racism, on the effects of different health outcomes for Native Hawaiians. And I have them listed here. One of the things we found early on is that we looked at the cortisol levels, diurnal cortisol levels among Native Hawaiians, we found a very strong negative association with interpersonal racism. And many of you might be thinking, well, it's counterintuitive because with stress, usually cortisol would increase in response to help the fight or flight response for the body to deal with the stressor. But actually with chronic stress, we actually see something different. There's a kind of a downregulation or a flattening or a blunting of the cortisol response and how the body responds to new stressors because of chronic stress over time. And racism is a chronic stress. And so we're finding a negative association. The more perceptions, the more experience of racism among Native Hawaiians, the more likely they are to have a flattened or a blunted cortisol response, a diurnal cortisol response over the day. The other thing we're finding is that it's associated with increased risk for hypertension among Native Hawaiians. And we actually controlled for other demographic factors and other factors that could explain away that association. And we still find an association there between racism and hypertension or high blood pressure, where other researchers have findings associated with obesity. And several studies that we've done already have looked at depression symptoms and psychological distress and found a very strong association. Again, controlling for other social demographic, in some cases, other medical or clinical variables that could explain away the relationship. But the association, a significant association still remains. Dr. Hermosura, I don't know if she's going to be presenting this, but I'll touch on it a bit for a study she did as a dissertation, which is really outstanding. And she looked at cardiovascular reactivity and recovery in Native Hawaiians in response to racial stressors. And how does, so if you don't, especially if cardiovascular incomplete recovery has been found associated with heart disease, future heart disease in other populations, such as African Americans. So as people respond to a stressor in the environment, they're going to react to it. Their blood pressure is going to go up. Their heart rate's going to go up because they're a little anxious, they're tense, they're fearful, something's happening. And so they react to that. That's the reactivity, how fast, how quickly a body responds to a stressful event. The recovery part is how long it takes and how much recovery happens after the stressful stimuli is no longer present in the environment. And of course, as I mentioned earlier, the longer that recovery or an ability to have a full recovery back to baseline has been found to be associated with future heart disease among other populations. And Dr. Hermosura cleverly designed an experimental study looking at racial stressors. And indeed, she found issues associated, similar findings, but more so what was interesting is that the subtle racism might be more damaging, more harmful than the blatant type of racism. Because I can go into that. Probably that could be a question to ask. For the sake of time, I'll continue on. Other than to say that it's having a physiological effect. Racism is having a physiological effect on in Native Hawaiians that is putting Native Hawaiians at a greater risk for chronic diseases in this case, but even mental health issues. Implicit bias work that both Dr. Delafield and Dr. Hermosura are doing. Dr. Delafield just published the work that she did looking at implicit bias among physicians, in this case, OBGYNs, toward Native Hawaiians and Micronesian patients versus Asian and white patients, and found a slight but significant bias toward Native Hawaiian and Micronesian when compared, well, in her case, Micronesian patients versus Asian and white patients. And this just kind of example of to show some of the pathways that we've been looking at, by which racism perhaps affects psychological distress in this case. And we're finding that there are other factors that we could intervene on perhaps. Racism, ideally, you want to eliminate it from our environment. That probably won't happen anytime soon, unfortunately. We haven't developed an effective strategy to make people treat others better. In the meantime, though, can we help others deal with the unfortunate circumstances of racism that it's causing in people's lives? And what we do know that the effects of racism, in this case on Native Hawaiians, and its effects on psychological well-being is operating through, in this case, through two coping strategies. We looked at 14 distinct coping strategies, 7 of which are considered active coping strategies. They're good coping strategies. The other 7 are what they call passive or really ineffective coping strategies. And what we're finding is venting and behavioral disengagement. Venting is anger, frustration, getting pissed off, complaining about it to a friend, to a family, ruminating over it and anger and developing this anger about it. Behavioral disengagement is probably what we might consider learned helplessness, for example. And we know that learned helplessness is associated with depression and other issues. They just disengage. There's nothing they can do about it. So nothing is done. But that doesn't mean it's not weighing on them. And going back to Hermosura's study on the cardiovascular reactivity recovery, as you saw, the subtle, or as I explained, the subtle could be more damaging. And it's a way, this is a subtle effect of racism on someone's psyche that may be putting them at risk. And others have looked at historical trauma and perceived discrimination. This study by colleagues over at the Cancer Center is really interesting. They look at Native Hawaiian students looking at substance use and the relationship between historical trauma and perceived discrimination. When you look at the direct effects between historical trauma and substance use, for some reason, it's a negative relationship. So less historical trauma, less reports of feeling negative or having an effect by this historical loss, the more substance use. But when you really consider the effects of discrimination in that relationship, it actually mediates and it switches the relationship so that it becomes a positive association, meaning that more experience or more negative feelings about the historical trauma or the concerns about the historical loss we have experienced as a people or as a person in their families is associated with greater perceived discrimination. And that is thereby also associated with more substance use. When we look at the work across the entire globe, across the world, in other countries such as New Zealand, Australia, Canada, as well as the US, that are looking at issues of racism and health outcomes. And Disparities et al. Out of Australia have done a lot of work in taking all of those studies and making sense of them, doing a lot of meta-analyses, a lot of systematic reviews. This is a rather older one. He's continued to do this, but it shows the same thing. And he, based on all of the research that's happening, and some of these research are large national research, so thousands of people are participating. Others are much smaller in size, but taking them all together, he's showing 3 general pathways by which racism, racist experiences, discrimination affects the health, and a lot of the work is among Indigenous people. So he does a lot of work with the Aboriginal people there in Australia. So this is very relevant to our populations as well, and it's very consistent, as you'll see, with what we're finding here with each individual study that I presented. Helps to put together is a piece of this bigger puzzle that actually Disparities is showing, is hypothesizing as the pathway from racism to health outcomes. And as you can see, one pathway is through assault, violence, and other things that affect our health and well-being. But the one in the middle there is psychological, at least to psychological stress. Studies, our studies are supporting that. Psychological symptoms, negative coping behaviors. One of our the study I previously presented points to that is happening in our communities. And the physiological stress response, like the 2 that I presented to you with the cortisol study and the cardiovascular reactivity recovery study among Native Hawaiians. So we're supporting, our work here in Hawaii is supporting this hypothesized pathway by Disparities and colleagues that leads to increased risk for both mental health and physical health outcomes. As you can see, he has decreased birth weights and adverse birth outcomes as an issue. You could put anything else in there because we're finding that there's a similar pathway regardless of what the health outcome or concern might be that is shared because of these social and cultural determinants of health. And finally, the other pathway is the pathway we often talk about, which is access issues, issues around SES, so denial of goods or resources or services for whatever reason because of racial discrimination. So that systemic racism issues, we're more likely to live in poor living conditions, decreased quality of care or access to care. So this is kind of what, and our work here in Hawaii is actually showing this and actually supporting, especially the middle pathway there that you see. Now, again, as I started with on a good note by sharing the health and well-being of our ancestors were actually better than our own today, as well as those who came to the islands at that time. I also would like to take a time out here to also reflect on the many positives that we have in our Hawaiian and Pacific Islander community in general. I recognize I'm focusing here on Native Hawaiians because a lot of the studies, most of the studies have been done with Native Hawaiians, but this can point us in the right direction for other Pacific Islanders as well. And we have a cult resilience and many cultural assets in our communities that we know are actually helping us to achieve health equity. For the sake of time, I can't actually present all the studies that are the intervention studies that we are doing where we promote cultural practices and culturally grounded approaches to health promotion actually show that they can be more effective than traditional health promotion strategies. But take my word for it. When you start making our interventions, our strategies more in line with the cultural values, practices, and aspirations of the communities we're working with, we find that one, they're more likely to participate in these health promotion strategies. Second, we also get better clinical outcomes as a result. And third, they're more sustainable because our communities want to do it and it makes more sense for them. So what are the strengths in our communities that we can leverage for health promotion? And of course, Native Hawaiians have been on this path to cultural revitalization, revitalizing our language, our other traditional ways of modes of living. And we're finding tremendous benefit from doing that. 93% of Native Hawaiians strongly identify with their Native Hawaiian heritage and culture, despite the large ethnic admixture among Native Hawaiians. So Native Hawaiians have multiple ancestries, Hawaiian, German, Chinese, and so forth. Despite, in fact, our studies show there is no significant association between blood quantum and degree of Hawaiian identity. We've done studies with Hawaiians from Ni'ihau on Kauai across the islands, and we're finding that there's no association. So 100% by ancestry Native Hawaiian is just as likely as a 25% to strongly identify, in most cases, exclusively with their Native Hawaiian heritage and culture. Studies from Kamehameha schools show that 80% of Native Hawaiians strongly believe it is important to maintain our cultural values and practices for our psychological well-being. There's been a lot of studies looking at adverse family situations. And despite a lot of the literature out there showing more adversity in our families, more issues, we do know that stronger family supports, especially emotional support in Native Hawaiian homes, have healthier Native Hawaiian children that are doing well academically, socially, and psychologically. And that cultural-based education strategies, I know many years ago when it was first considered, it was very controversial, has proven to be very effective. And again, Kamehameha Schools has published a few studies. Some of these were done within our public school systems in which cultural-based education strategies within a classroom compared to those that did not utilize a cultural-based education strategy actually led to better academic performance among our Native Hawaiian students, more cognitive and emotional engagement, more education and community engagement, and greater cultural pride and sense of place. So tremendous benefits that we're seeing from cultural-based education. So Native Hawaiians are returning to our cultural traditions to improve our health and well-being. And you can imagine for a long time, we were deprived of this ability and almost lost a lot of things. Our language was on the verge of extinction, but luckily in the 80s, through our immersion programs, it has been revitalized. And we are seeing tremendous benefits as a result of cultural revitalization. I want to just end it briefly by saying that, we need to take a culturally responsive approach to dealing with issues, whether it's reducing the disparities that we see in maternal mortality or infant mortality or other issues that are disproportionately affecting our communities. We need to start looking at it through a different lens. The biomedical lens is insufficient for us to really truly address all the issues that are upstream that affect the health and well-being of our communities. And when we work with Hawaiian patients or clients or community folks, historical trauma and racism is always an underlying factor, whether it's directly related to their concern or indirectly related. I have not done a focus group and interview over the years, regardless of what the topic might be about, that the issue of cultural loss, the issue of discrimination has not come up as a salient factor in our communities. And so it's an ever-present stressor, and it's a chronic stressor that is associated, and we find this not just with Native Hawaiians, we've long understood it among African Americans, for example, and other populations, that it does affect the health and well-being of our communities. And that we can do something about it, as Dr. Delafield pointed out. It's modifiable, it's human-made. It's the political decisions that we make or don't make. It's how we allocate resources and attention. It's how we create, it's the narratives we create to explain the situation others are in. And if we continue to foster these false negatives that there are truly genetic and biological differences due to race, and ignore the other factors that are associated with race, such as racism, discrimination, access issues, and so forth, we're never going to achieve health equity. We're always going to be band-aids. We're always just going to be putting out fires. It's always going to be disease management rather than disease prevention. We need to start taking a serious look upstream. We need to change our systems and look at provider issues. You know, and we'll hear later, so I won't talk much about this, but we're finding that there are patient-provider issues. Our Native Hawaiians, our Pacific Islanders don't feel safe. They're not culturally safe in our settings, and we need to change that. And there's therapeutic issues. More and more, as we revitalize our culture, our younger members of our communities are now bilingual. They speak Hawaiian and English. They think in Hawaiian and English. They behave in Hawaiian and other ways. They are looking to look at other traditional Hawaiian healing modalities as ways for health promotion, as well as treating some of their health issues. And we need to start looking at that, incorporating that, and looking how we can leverage that to increase screening, to increase people going in to see their primary care physician, and to increase the value that they may put in Western medicine. But we have to start looking at the value that is there in our traditional healing modalities. In summary, colonization is a key determinant of mental health for Native Hawaiians and Pacific Islanders. I'm sorry, I excluded that. That is a tremendous issue for our communities. Historical trauma racism affects Native Hawaiians in both in and indirect ways, and it certainly is certainly the upstream factor that affects all the other determinants of health for Native Hawaiians and Pacific Islanders. And with that, I end my discussion, and I now turn it back over to Dr. Delafield and Hermosura.
Thank you so much, Dr. Kaholokula. I know there was a lot of interest in your talk, and I saw some engagement in the chat. So we'll get to those questions after we finish. So one of the things that we're going to do is kind of tack on to the last part of Dr. Kaholokula's talk in terms of looking more specifically at system and provider issues. And so Dr. Hermosura and I have been partnering on this topic for quite some time now, looking at implicit bias and specifically healthcare for Native Hawaiian and Pacific Islanders. So, you know, the history that Dr. Kaholokula went through is often hidden when people present at a service, either at a health center or at a school or at a social service. But the impact of those traumas have resulted in where they have ended up, right? In terms of needing extra support because of lack of education, or because of multiple illness, or because of histories of trauma, incarceration, etc. So these conditions, as they present, sometimes become the only story that the community sees and the perception of someone from that community. And so we're going to talk a little bit about the problem that creates for people. So just to give you some background, our focus for this talk is as health disparities researchers. And so we come to this discussion through that lens, and we entered into conversations about implicit bias through that lens and trying to figure out how implicit bias is impacting these disparities in health. But research around Native Hawaiians and Pacific Islanders specifically did not exist. When we talk about implicit bias, oftentimes the studies we have to reference, and this is also actually mirrored in terms of maternal health outcomes for them a lot, is that we talk about what we're seeing in other racial minority communities. So differences and pathways that are identified in research that focus specifically on African Americans, that we extrapolate those pathways to our groups. So we're building the information and the research around these topics. And that's what Dr. Hermosura and I had to do, in essence, is that we are starting to try to address and measure implicit bias for Native Hawaiian and Pacific Islanders. So we started investigating this area out of the recognition that context it matters, and that Hawaii's context presents a unique history compared to some of the other groups that have been looked at in terms of the cultural and social influences and how biases are presented here. So the actual presence of racism exists, and you can see it through those histories of colonizations, but how those are witnessed and who they impact here can be a little bit different and harder to see when you're just looking at the research from the continent. So we're specifically looking at Native Hawaiians because we're affiliated with those communities, but that doesn't mean to diminish the experiences of other groups. And also we focus on racial implicit biases, understanding that there are other isms that create inequalities and biases for other groups that intersect with identities. And actually looking at this issue around maternal health starts to intersect with sexism as well. And when we talk about maternal health, again, the language hasn't caught up with the actual realities, and that's so common. So when I talk about maternal health outcomes, I'm using that so that I can be clear and express my meaning. But the reality is that there's people who it's not a specific gender that I'm talking about. It's an actual experience of pregnancy and delivery. So to be clear about that, and when the gender doesn't match like a typical gender, then you add on another aspect of inequality and services that can be challenging for people. So I wanted to make that clear as well. So what we're going to do now is present a composite of an experience that is gleaned from a lot of the different research and conversations we've had with patients. And so this is just one example of how subtle biases can begin to impact people. So we're gonna just share this, and I just want you to marinate on it a little bit as we go through the rest of the presentation. So this is a story about Keawe. She moved from Washington to Hawaii in her 14th week of pregnancy to be closer to family. And it took 2 weeks to get insurance because her partner had just started his new job. She goes to her first prenatal care visit since moving to the state, and the clinic staff immediately asks what Medicaid plan, MedQuest plan she's on. And Keawe says, I have private insurance. The clinic staff breathes a sigh of relief and says, oh good, healthcare is not free. But when she turns in her paperwork, clinic staff says, you're now registered, but sorry, our system can't take your full name, so it's just under Keawe. Keawe also overhears nurses talking about a patient, the only other Native Hawaiian patient or seemingly Native Hawaiian patient in the room. One of the nurses says, did you hear she has to be delivered because early because she's so big? Why can't Native Hawaiian women manage their weight, at least when they're pregnant? So again, this is just a composite of some experiences that we've heard from other from the research that we've done. And this is a quote that I want to share that really speaks to what happens when someone presents and you only see the single story. And the quote is from Chimamanda Ngozi Adichie, who is has a great TED Talk called The Danger of a Single Story. And she says, the single story creates stereotypes. And the problem with the stereotype is not that they're untrue, but that they are incomplete. And so that's what we want to focus on today, and what we tried to help give you through Dr. Kaholokula's talk in terms of giving you this history of how health has been formed and shaped by these historical and social occurrences, and then talk today about some of the things that he mentioned in terms of racism. So this is just a definition of racism from Dr. Kamara Jones that we use when talking about racism, so that people understand it's not just interpersonal slights or poor treatment at the individual or interpersonal level, but it is this system of structuring opportunity and assigning value based on the social interpretation of how one looks that unfairly disadvantages some groups and individuals and unfairly advantages other individuals and community, which ultimately saps the strength of the whole society, because then you're wasting all the potential that you have within your full breadth of humanity. And racism and discrimination are fundamental determinants of health and illness. So stereotypes and other systemic forms of oppression feed into our society and communities about these groups. So what happens is they can influence, these stereotypes can influence what we associate with different communities. What we need to, the reason why we need to define racism is so that we can recognize the legacy of racism and the histories of colonization and imperialism across the Pacific, so we understand how these stories have shaped the way that our Pacific Islanders are perceived and viewed, and then how policies and practices have operated to marginalize their own stories and voices in contemporary systems and structures and institutions. So this is the work. This is a definition of bias. We have both explicit bias here, which is a positive or negative attitude toward a person, thing, or group that a person is aware of and is under their conscious control. And then there's implicit bias. And that's a positive or negative attitude or stereotype towards a person, thing, or group that is outside of conscious control. So these are not mutually exclusive and may reinforce one another. And one of the things to note is that you're continuing to learn these implicit and explicit biases. The way you learn them is the same. It's just the awareness of learning them can be different. So implicit biases are a part of natural brain processing, right? So the unconscious sorting and associating of things is helping people deal with all of the millions of bits of information that come in. So in a sense, the process of that is very much natural, and it helps us to function and think in an environment that has a lot of different stimulus and a lot of different things that we have to respond and react to and make decisions about. And these biases, again, are learned from the context and the environment we're in. So somebody put in the chat nature versus nurture. So this is very much kind of, the nature is, we are built to create these associations unconsciously to help us perform, but the nurture is how those associations are built. So the way that we're raised, the place that we're raised is going to help us associate different things. However, racial biases are not inherent. So racism is something that we learn through our environments. And that's the kind of the lesson from some of the work that's been done on large scales implicit bias, is that implicit biases towards that show a preference towards white groups are learned at our national, like in a national scale. And so that's an important distinction, that there's something that we can do about it. And it's not just about individual changes, but it's about recognizing the social messaging that is teaching racism in our society. So exposure to stereotypes can contribute to the formation of biases, and these implicit biases are thoughts. They're part of a thought process, but they can influence behaviors and decisions. And that's a lot of what the research in this area is focused on. How do these implicit biases that we know exist actually influence the behaviors and the decisions that are being made, and particularly in the area of healthcare? And then implicit biases can result in real world effects. So again, discrimination. And they may not align with your individual values or beliefs or your institutional mission and goals. And that is why we're talking about it. And that is why we're grateful you're here, because people do not want to be impacted by the racism. And they certainly don't want to do it when it doesn't align with the mission of their agency and the goals that they have as an individual. That said, those biases are around, and as we continue to live and exist in a society where the messages, subtle and explicit, are being shared, then we are at risk of kind of downloading those associations. So this is just a figure, and I'm going to be sharing some resources at the end through the chat, but this is from Kaiser Family Foundation, just to show you that, you know, this is not just us talking. Racism and discrimination are pieces that affect all of these areas of our society. And we're focusing here on healthcare, but that is just because that's our specific area. These all are tied to other sectors of society and experienced by individuals who are targets of racism in all these different sectors. So Dr. Hermosura, I can advance the slides for you if you want.
Thank you. So thank you, Dr. Delafield. And I'm going to focus specifically on bias in healthcare and kind of talk about some of the issues that arise because of implicit biases. And so the first issue is that most of the studies that have been done on implicit bias in healthcare have been has looked at Black versus white implicit preference. And so that's the groups that have been compared the longest in our literature. But like Dr. Delafield and Dr. Kaholokula said, initially, we don't have as much data on Native Hawaiians, and we have even less data on Pacific Islanders in this area. And the reason why it's important to look at these issues is because implicit racial bias among healthcare professionals is similar to bias found in the wider population. So healthcare professionals are exposed to the same societal narratives that everyone else is, and are not immune to being impacted by those narratives and how they manifest in our different settings. And bias in healthcare has been linked to health disparities that we see in healthcare quality and outcomes. And right now the literature is mixed on how that manifests, especially in terms of like decision making. But the way that it consistently shows up is in our patient-provider communication and relationships. And a lot of the time we see it in nonverbal communication. So there's more verbal dominance when someone has a stronger preference for the dominant group versus the minority group. There's more negative affect on the provider's face when they're interacting with certain populations. The dialogue that happens tends to be slower, and we can assume what that might mean to the provider. And then there's less patient-centeredness, so less time spent looking at the perspective of the patient. And like I mentioned earlier, there are studies out there that have looked at how implicit biases influence diagnosis and treatment decisions, but they're a lot less common. And one of the most famous studies is by Green, and he looked at Black patients who come in for a myocardial infarction and how they're less likely to get the evidence-based treatment of thrombolytic therapy than whites when a provider has a stronger pro-white preference and anti-Black bias. Next slide, please. And so we're going to revisit Keala's story. I saw some of the chat conversations just talking about how often that story shows up in your clinics. But I think we wanted to highlight that Keala comes into the clinic really wanting compassionate and respectful care, and she wants to feel welcomed by providers and staff. And in this example, she's really greeted and experiences a lot of the microaggressions from the front, the PSRs or the medical assistants that are manning the front desk. And so it's really important to look at how biases can manifest across all groups of providers and staff that are a part of your system. But what she ends up experiencing is microaggressions, right? So this assumption that she's on MedQuest. There's also an example of patient blaming or stigmatization. So talking about the other Native Hawaiian woman who is overweight, and there's an assumption that she doesn't care about her health or her baby's health and is not doing the right things to maintain her weight during her pregnancy. There's also some devaluing of cultural values. So, you know, in the EPIC system, if we talk about EPIC or other electronic medical records, not having enough letters space to put in a person's entire name indicates that the system wasn't set up for that group or population, and it can create a sense of distance between the system and the patient. And then, of course, it being an unwelcoming setting. So when you overhear people talking negatively about others, then you might assume that they're talking negatively about you. And when it's based on stereotypes, then like Dr. Delafield mentioned earlier, they're only based on one part of the story. And so how many people get the full story? And that's why we really appreciate what Dr. Kaholokula shares about the history and historical trauma of Native Hawaiians and Pacific Islanders and how that can impact care today. Next slide, please. Sorry. And so we also wanted to highlight the relationship between experiences of trauma and implicit bias. And so historical trauma really leads to established stereotypes. So one of the most common stereotypes that we found in our research, Dr. Delafield and I, about Native Hawaiians is this association between being unintelligent and being Hawaiian. And if we go back to what Dr. Kaholokula talked about with historical trauma, when you abolished Hawaiian language, for example, from the educational and political system, it really puts a whole population at a disadvantage. And so they're forced to quickly adapt to a system that wasn't created for them and to talk in English. And so that the stereotype of being unintelligent could have started back then, and it's perpetuated over generations now. And this is interesting because at one point, Native Hawaiians were the most read population with over 90% literacy rate. And Native Hawaiians also had, or King also had, electricity at Iolani Palace before the White House and Buckingham Palace. But when we talk about these examples, oftentimes they're seen as the exception rather than the rule. And so thank you, Becky. So one of the other things is that present day and interpersonal trauma and racism that we talked about, it reactivates these stereotypes and it reinforces the biases that we have. And groups or individuals become targets of biases and discrimination, and that can lead to health disparities that we see today. Next slide, please. And so I'm going to talk a little bit about different individual strategies we can use to manage our bias. So like Dr. Delafield said, they're malleable. And I'm going to just highlight a few. And if you're interested in the article, I can send that out as well. But the first thing is mindfulness. Our biases are mostly activated when we're under stress. And so the way that I learned bias is mindfulness is it's the intentional use of attention. And so if we stay present in different moments and incorporate as many of our senses as possible into that moment, the more likely we are to be present and the more likely we are to feel less stressed, and then our biases are less likely to be activated. There's also counter-stereotypic imaging, right? So we just heard a very intelligent Native Hawaiian man, Dr. Kaholokula, share his research and our research with all of you. And so how do you replace maybe the images or stereotypes that we have about a group or a people with those that counter that stereotype? And then also individuation. And so that's when you look at individuals of the target group based on their personal rather than their group-based attributes. And then finally, increasing opportunities for contact. So it's really important to engage with people who are not from groups that you're familiar with so that it can help to change the ideas and perceptions you have about that group. Next slide, please. So individual strategies are important, but institutional and policy related strategies are more effective at managing bias. And so we really need to look at implicit bias as a public health problem, one that we all need to work on in order to shift the culture that we live in and support programs that intervene at an institutional or policy level. And then make identifying inequities a standard practice. And in order to do that, we need to disaggregate data by race and ethnicity, for example, in order to better understand the issues that are coming up. We also want to prioritize the use and development of strategies based on bias prevention rather than strategies based on individual and group anti-bias initiatives. So the stereotypes that we learn, the attitudes that we form are because of larger societal issues. So what policies, procedures, and norms are in place that in our organizations and in the groups that we work with that perpetuate a lot of these stereotypes and biases. And then use caution regarding remedies described as training. So training is like the initial step into this conversation, but you need a lot more ongoing work in order to shift the biases that we have. And then last, integrate diversity, equity, inclusion, and social justice efforts into your organizational structure at all levels. And so one of the things we like to do is just ask you some questions about how you can apply this in your own work so that it translates into action. But these are the questions. And then Dr. Delafield is going to briefly talk about our new initiative.
So thank you so much for taking the time again to listen. I'm just going to give you a couple different pieces of information. I think there'll be some stuff that'll go into the chat. If Chelsea, you could put some links into the chat. I just wanted to share with you that Dr. Hermosura and I are part of a collaborative called Hawaii Implicit Bias Initiative that is working on collecting data and also eventually building out education and some training around implicit biases that are salient for Hawaii. We have currently launched this website and we're accepting where people can take implicit bias tests that are tailored to our particular populations. And we're at this point asking people to take it out of the goodness of your heart and try it out. If you would take them, one of them or two of them to see what it's like. And then there'll be a link in the chat where you can give feedback. It's going to be called like a Google form. Right now, these tests are kind of, this is our soft launch period, and we're making sure that they operate correctly. There's no glitches that you encounter, and also to make sure that give us some time where we're going to build out a situation where when you take the test, you can see your result immediately. And having some people take tests, then we'll be able to give some context when your feedback is given at the end of the test. So if you have questions, you can ask either one of us about it. If you don't mind, Chelsea, could you also put our contact information into the chat as well? I've also included some different resources on publications on maternal health and some resources on maternal and perinatal health for Pacific Islanders in the chat. Then the other thing I wanted to mention is that there were some questions about, how do we understand and the experiences and get more attention and training for different providers. The project that I'm working on now is trying to look at experiences for Native Hawaiian, Samoan, Tongan, Marshallese, and other Pacific Islanders about their experiences in maternity care. And I did interviews with 26 women, and some of those quotes were shared, but this is a survey that uses that information to tailor a measure that looks specifically at provider communication and relationship and ask questions about discrimination. So if you are anyone who is in contact with this particular population, please look out for this or let me know that you would be able to help share this out. I'm looking for about 200 surveys to go out for women to take, and it takes less than 30 minutes, and there is an incentive. So contact me. So thank you so much. There's some additional references here. And then we just wanted to say thank you to the people who have supported our work. And again, to Department of Health and Maternal and Child Health Branch and to HCAN for hosting us. So we have a few minutes for questions, and I'm going to stop share if that's okay.
One of the questions I saw was about whether or not are we looking to New Zealand for some solutions, because as you presented early on, they seem to have lower rates of maternal deaths and so forth. I'll speak quickly to that. Yes, we're always looking to our Maori colleagues and New Zealand for examples. They do have a different political relationship in their country because they are recognized as sovereign. They have the Treaty of Waitangi. They do have certain advantages because of that, and considerations at the highest levels that do allocate funding and resources. And they had initiatives that, and I saw one of the questions was around growing our own from our communities. I totally agree with that. We need more Native Hawaiian Pacific Islander physicians, psychologists, social workers, health professionals, health administrators across the board. That's something that will really definitely contribute to achieving health equity quicker, faster. We definitely do look to our colleagues in New Zealand for some of those answers. But I do think some of the unique political relationships and hopefully, of course, here we can achieve some of that, but that's also a big barrier to us expediting the process of health equity.
Yeah, she's on the blanket, so I'm leaving it here.
Yeah, she's been fighting with it the whole time.
I know.
Oh, thank you, Chelsea, for putting this up. There was a question about the the study about implicit bias. So we actually, the finding, so that was a small study using these new tools that Dr. Hermosura and I created. It was part of my dissertation work, and we looked at implicit bias again towards what we called Micronesian. We use that term intentionally as Micronesian has become a racialized identity in Hawaii. So we use that term to understand how racism is impacting the communities that are actually self-identify as Pohnpeian or Marshallese, etc. Compared to white. And then we also had another condition where we compared Micronesian to Japanese American. So the results of that study showed a slight pro-white bias, anti-Micronesian bias among a small sample of, I think it was around 29 practicing OBGYNs in Hawaii. And there were some heavily associations in terms of some common ones that we see, like less pro-white bias with female respondents and less pro-white bias for younger respondents. But we also kind of may have underestimated it because there were a lot of people who were in training who tended to have a lower bias, and they had not then lived in Hawaii for as long too. So we were thinking that that might have contributed to the outcomes. So that was just a small study, and we intend to look further again in this implicit bias initiative. Hawaii Implicit Bias Initiative is part of that. So we'll be collecting demographic data about different sectors of the community. So we'll hopefully be able to generate greater amounts of research and bigger sample sizes to understand more how these associations work and control for different variables. There's so many questions. Andrea or Keawe, do you see one you want to take?
Well, I see one from my hall. What would it take to have our cultural practices such as lomi, la'au, lapa'au, and others covered by insurance so more of us can access these wonderful services? I believe someone else responded about some of the Aloha Care initiatives that are happening to support some of that. I think we need more of that. I think we need more of our medical insurers to value our practices. At the same hand, we need to also demonstrate the benefits of our practices for health promotion. And the more we can do that, the more I think we get these things reimbursed or at least considered. And so I think there is a possibility. I think Aloha Care is an example of that heading there. I know Ke Aloha Fox is working tirelessly on getting more of our cultural practices reimbursed for as services, as viable health practices.
I think there was a question about how can OBGYNs and other maternal health care providers be reached to engage with systemic change and improve maternal and infant health outcomes through culturally responsive approaches. So really that's kind of where the research is building towards, mine and hopefully others. I think there are other people who are getting really interested in doing different things in different aspects of, that big conceptual model that Dr. Kaholokula shared. And so my hope is that I will be able to take some of the research that I did to create an intervention to do kind of a multi-level program and test how we can better train and educate the clinicians that are working with our Native Hawaiian and Pacific Islander groups, and also what we can do to support our Native Hawaiian and Pacific Islander groups through community. And so I've been working with communities and sharing my research with them. And I've just applied for a grant to try to get funding to take my work to the next stage.
And there's been a couple of questions. I think Mele Andrade had posed a question about how do we make the practices we're talking about evidence-based. And I think there's just a general question about what is evidence-based, and I'll just briefly share. I always have concern about what others have termed evidence-based, because we need to remember that the evidence of any intervention, the efficacy or effectiveness of that intervention is really tied to the sample in which they was tested. Now, if our interventions were tested predominantly with majority groups, and did not include people from our communities, I don't consider that evidence that it works in our communities. Good science would dictate that it's really contingent to, it's really based on the sample, and that we need to look at whether or not it actually works in other populations. But unfortunately, that's what gets promoted and funded as evidence-based, right? So we need to look at it differently as one thing. I'm not totally convinced that we need to entirely do these really long, expensive, rigorous controlled trials to demonstrate evidence that we could begin to initiate immediately. I think there's other forms of evidence that we can also look at. I don't think we have the time or funding to wait that long to get these services out. So I think we need to be a little more creative and a little more flexible. Again, that requires us to work with decision makers around this on changing their policies and criteria and so forth around what is doable, what's not doable, what's fundable and not fundable. So it's a work in progress.
There was also a statement about frustration in terms of the requirement for language services, but no interpreters available. And I really think that's an area where we can do so much more in terms of advocacy. I think we have well enough evidence that we are not providing the kind of access, not just in health, but in so many other service areas for the population that needs the most access. And one of the reasons is because we rely on national services. And so they don't have the number of speakers at the times available that we need, because our demand is so high for those particular Pacific Island languages, specifically Chukis and Marshallese. And so we need to do something on our own to serve our community for a need that's been well documented in research and in practice. So I'm hoping that that is a way that, public health, but other agencies can center equity and make those things a priority, so that when other issues come up, and just in terms of regular care services, people have the kind of access that they're supposed to be getting through law.
Becky, I think Andrea can answer one of the questions really nicely, given her work on cultural safety versus cultural competency. I think one of the earlier questions I saw was really around how do we change systemic level. I know you touched on that a bit on implicit bias, but Andrea, and this goes back to the drawing from New Zealand examples. Andrea, you want to share a little bit about the cultural safety versus a cultural competency framework and kind of the work you've been doing at Queens and elsewhere?
Yeah, I can definitely share about that. So I think, traditionally we've looked at cultural competency as something that providers achieve or the system achieves, but there's been a paradigm shift to look more specifically at cultural safety and putting the onus on the systems that we operate in rather than the patients or the providers that work in these systems. And I think there's a lot of opportunities to to shift that and to look at specifically, I think Amanda talked about like big picture things and what are the things we accept or what are things that we shouldn't accept in our current systems and the ways of being. And so I think looking specifically at policies, practices, and norms that we've subscribed to without really questioning where they came from, why they exist, and to Dr. Kaholokula's point, what is evidence, the evidence for it? And are we just taking things from continental systems and plopping them in our own organizations and really challenging the norms and creating safe spaces to have these conversations, these really difficult conversations, despite pushback that we may all get from leaders and others who think in that way often. So we can talk more offline if you want, but there's so much work to be done in those spaces and the spaces that I work in at like the university and at Queens.
You know, I gotta say, Becky, I just want to make sure that everybody's clear. You know, I know we presented some studies. We talk about some professions and subspecialties within medicine and elsewhere. It's not to pick on any group. The implicit biases, we all have it in many different ways, whether they're racial, whether they're in other ways, and it's often competing sometimes with the actual values that people hold. It's just this learned history, as Becky had pointed out. So I just want to make it clear because I don't want it to seem like we're picking on one profession over the other. Unfortunately, there's just been more research in one area and so forth. But it's something across the board, and sometimes even among in our own communities. You know, there are Native providers that hold negative attitudes towards their own people and communities as well. That also gets in the way. So it's not just unique to people not from the racial ethnic group. So it's across the board, and we need to recognize that, because I don't want you folks to leave here pointing. We don't want to point fingers anywhere where we don't need to. And as I think the point of this is really a systemic issue, and that it'll take all of us to really address effectively. But I just like to
excellent point, actually, because someone asked about current educational structures and how they operate and how we work within them. And so, you know, there's been a push and a growth in Hawaiian immersion programs, for example, and anecdotally, even though schools have Hawaiian immersion programs, some of their practices don't necessarily align, and the biases that they hold manifest in different ways. And so for an example is my son goes to a Hawaiian immersion program, and every time I call the front desk to say that he's sick or he's not coming in, they'll ask me if his Hawaiian name is his legal name. And so finally, I said, yes, it's his legal name. Do you ask all parents whether or not their English named children is their legal name? And I say that I shorten it for the school and for the staff. But just understanding how your questions, how you come across can really influence how people feel in the spaces that you attend or operate.
mahalo to everyone.
Thank you. I see there's one, just more of a comment here to, there's implicit, explicit bias that pregnant people don't even know how to birth babies on their own. So there's a layered bias, and it is also something I wonder how we will talk about and tackle as a community. So yeah, that's something that came up in my some of my conversations with women in the 26 interviews that I did recently, talking to them. I think there was one quote that I've shared when I presented to community, just like this woman who had already had many children, and she was saying like, oh, I know that I'm about to deliver this baby, but because she wasn't at the place the nurses who were in the room thought she would be or should be, they didn't believe her, and so she felt like she delivered the baby on her own. So in that sense, it's, you know, she wasn't being listened to, and her expertise and her data that she has from being someone who had birthed several different babies in the same body was kind of ignored. And so that's something that I think the work that I'm doing, and also the work that's being done with other studies that are looking at the maternal birth, the birth experiences of minority women across the state are talking about. And so I think, it is a real conversation. So much time has been devoted to clinical training that says, like, basically you need to get this amount of expertise because you have to be able to save the life when life is in danger. And that's absolutely something we rely on, right? But we also have to figure out where we can find the line, where we also give the time and attention to listen to women who are telling their stories and their experience and using their knowledge to explain. And, it's really a difficult challenge because we have so much of our healthcare is about an industry rather than about, the health of our communities. And so I think there's a lot of work around advocacy and really asking some difficult questions in order to make the changes that we need to have happen to make healthcare better. But you can see in the differences that we have in terms of that's one of the reasons why I wanted to give that global information, right? And the comparisons is that we have so much money, more money than any other country going into healthcare, and such poor results, and particularly for women in our communities. So I think that's all the time we're going to be able to take, but the Google Doc will be helpful. And if you want to reach out to me, I can try to address any questions that you had remaining. We put our contact information in the chat. Dr. Kaholokula, is it okay if I put your information in the chat too?
Yes, it's
Okay.
good. I see Lena has asked a question about during training, and maybe she can contact you directly about that.
Yeah. So you can contact us. I think one of the missions of Hawaii Implicit Bias Initiative is to try to come up with something so that we can help provide or at least support the trainings. There are other people that do trainings too. So, if you have questions about that, please feel free to reach out. And thank you so much for spending the time here and for lingering with us. Sorry to keep you over, but so appreciate your engagement and interest in this topic.
Mahalo, everyone. Aloha.
Thank you, everyone.
Aloha.